Hello everyone, I'm Dr. Lahari here and welcome to this lecture on General Principles of Radiographic Interpretation. This is a two-part lecture and I will be covering it in part 1 and part 2, and this is part 1 of the lecture. The learning outcomes will be to understand a step-by-step analytic process that can be applied to interpretation of radiographic images. When we're talking about prescribing dental imaging, there are certain important points that need to be kept in mind. Number one is the need for imaging. Do we really need to take an X-ray for this particular case? And if yes, which is the kind of radiograph that would be useful? For example, if when the abnormality that cannot be assessed fully clinically during clinical examination alone, or when the disease is not clinically evident, it's important that imaging comes into play in aid to diagnostics, and x-rays are then of help. Also, it's important to check any previous radiographs or previous imaging done. So that's always useful to understand that how the disease was probably a month ago or 2 months ago and how is it at the moment. Administrative radiographs, for example, taken for insurance claims, are some things which I personally do not recommend or shouldn't be done too often unless they are absolutely mandatory. And of course, radiographs taken for special considerations, with special considerations like during pregnancy or radiotherapy patients, it's important to keep in mind that less is more. So, and always abide to the principle of ALARA. Now, these are examples of cases and the type of imaging that would be the best for that particular case. For example, a 10-year-old child coming with mixed dentition and a stainless steel crown and deciduous molar done 4 years back with tight contacts, and you want to assess the area. So, a bite wing would be the ideal type of radiograph which could help you assess the case. A 26-year-old with a fractured incisor restored 6 months ago, who's currently asymptomatic and the vitality tested normal, you ideally don't need imaging for this kind of a case. A 65-year-old, multiple carious teeth with 7 pockets in most of the teeth, then a full mouth series examination of IOPARs or dental radiographs would be the ideal imaging of choice, because you want to look at the depth of caries in detail, as well as you want to assess the bone loss in detail. So a full mouth examination would be a lot more convenient in giving you more details than a panoramic radiograph. An 18-year-old with impacted third molar and three quadrants and probably symptomatic only on one side, even then a panoramic radiograph would be one of the best choice of imaging in this case. 45-year-old who's indicated for a single tooth implant. First, the radiograph to be taken would be a periapical, simple single periapical of that area, followed by a panoramic to visualize the scout, like a scout image or a screening image to see if there are any other abnormalities. Then a small field of view CBCT would be the ideal choice. Lastly, a 5-year-old, first dental visit, no evidence or no clinical evidence of caries, you do not require imaging at all. So, like I said in the previous slide, administrative imaging for just getting the case done or just to keep a record or just to make your patient happy is not recommended, because any amount of radiation, especially in case of children, is to be avoided. Let's come to the principles of radiographic interpretation. First of all, acquiring the appropriate diagnostic image is the key. So, to identify the best image possible for your case, it's important to keep in mind that what is adequate to see the area or to be imaged. If it's a single tooth or a couple of teeth, it's important that probably an IOPAR would be more than enough. But if you're looking at more detailed area, like you want to place an implant, then you probably require a CBCT. So the hierarchy of imaging should be kept in mind. Also, are single images enough for the case, or do you require multiple images? When you're doing plain radiograph, let's say you want to see one area and you're not satisfied with the way the appearance of the tooth is. Let's say it's a root canal treated tooth and you're trying to assess if the root canaling has been done well. So you might want to take another image with the shift technique to assess all the canals, whether they've been filled or no. And when do you apply advanced imaging? Now, other than acquiring the appropriate diagnostic imaging, the next point is to have ideal viewing conditions. Also, systematic image analysis needs to be done. So, especially for the novice dental practitioner or dental students who are understanding or trying to assess images for the first time, or who have less experience, it's important to follow the radiographic interpretation format. The simple format in of dental radiographic interpretation, for example, following the crown root, starting with normal landmarks, following the crown root, periapical lamina dura, PDL space, and then coming on to the apical region bone, would be a best method to analyze the image without missing any points. Lastly, application of diagnostic reasoning in dental radiology is something which is acquired, and the skill can be acquired by viewing more and more radiographs and correlating it to the clinical findings, and looking through the images again and again to understand what is normal versus what is abnormal. What happens is we tend to form a mental 3D image of the lesion in our mind, and this complex perceptual image identification is what gets retained in the brain, and each time you look at it, the eyes send the signals to the brain and you identify it as normal versus abnormal. So what are we going to look at? We will be looking at dental caries, periodontal disease, inflammatory lesions of the jaws, cysts, benign tumors, malignant tumors, diseases of bone, systemic diseases, paranasal diseases, dental anomalies, developmental disturbances of face and jaws, as well as trauma. To analyze intraosseous lesions, there are certain steps that have been laid down. Step 1 is to localize the abnormality. Step 2, to assess the periphery and shape. Step 3, to analyze the internal structures. Step 4, analyze the effects of the lesion on the surrounding structures. And step 5, finally, to formulate a radiographic diagnosis. So following this 5-step method would be easy to go about any radiographic interpretation of a lesion that you're looking at on a larger radiograph or a smaller radiograph. So step 1 is to localize the abnormality. When we're talking about localizing, it's important to assess where the location of the lesion is. What is the anatomic position? Where is the epicenter? Where is it originating? Is this lesion localized or generalized? Are you looking at only one area in the entire jaw having this particular either radiolucency or radioopacity, or are there multiple such areas? Is it unilateral or bilateral? Is it single or multifocal? So these are some things which you need to keep in mind as a step 1 of the process of interpreting a radiograph. Step 2 would be to assess the periphery and the shape of the lesion. When we're talking about the periphery, we're talking about either it being well-defined, punched out, corticated, sclerotic, or having a soft tissue capsule. So these are the common terminology used in radiology to describe the periphery of a lesion. Following this, you could also talk about ill-defined areas which could be blending or invasive. When we're talking about shape of the lesion, we usually use the terms like circular, scalloped, or irregular when you can't define the shape properly. This is examples of well-defined corticated borders. Here you can see in the examples listed here that the lesion seems to be pretty rounded, circular, and having a nice sclerotic margin. In the first case, this is an example of an impacted tooth with a well-defined radiolucency around the crown. And the second case is that of a central and the lateral with a well-defined radiolucency arising from the apex of a tooth, as well as the third case, which is showing you a root stump with a well-defined cystic radiolucency. So this is what we call as a well-defined corticated border. On the other hand is a blending radiolucency, where you see that the margins are not very well defined, and then the margins of they blend into the adjacent normal looking bone. So this is called as a blending margin, and in this radiograph you're seeing that there's a radioopacity where the margins are actually blending again into the normal bone, and you cannot really define the edge of the lesion. This is an example of multiple punched out radiolucencies. This is a true skull view, and this sort of appearance generally is seen in multiple myeloma. And this is a very old radiograph. We generally don't do skull imaging of this sort very often these days, and it's mostly either a CBCT or a CT scan. But this kind of appearance can be seen in all kind of radiographic imaging, and is called as punched out radiolucencies. The radiolucency appears as though you've used a punch and made multiple holes. Step 3 would be to analyze the internal structure of the lesion. Is it totally radiolucent? Is it totally radiopaque? Or is it mixed? When it is mixed, it's important to describe the pattern that is visible in the radiolucency, or in the lesion itself. For example, in the first radiograph here, you see a completely radiopaque lesion surrounded by a radiolucent rim. Whereas in the second radiograph, you see a ground glass like appearance, which is very typical of fibrous dysplasia. And the description of the pattern, that is ground glass or orange peel, are commonly used in radiographic terminology to describe the trabecular pattern, which is not normal. Step 4 of the analysis would be to analyze the effects of the lesion on the surrounding structures. The surrounding structures we mean would be the teeth, lamina dura, or PDL space. What has happened to the inferior alveolar canal or the mental foramen? Has the lesion invaded the maxillary sinus? How is the surrounding bone density and trabecular pattern? And is the outer cortical bone intact? And is there a periosteal reaction? An example for this that you've seen here in the pictures would be the effect of the lesion on the mandibular canal here. In both these lesions, you see that the mandibular canal has been involved. The lesion has managed to push the mandibular canal or involve the mandibular canal. Coming to step 5 of the analysis or radiographic interpretation is formulation of a diagnosis. So, this is the final step. So, when you are formulating a radiographic diagnosis, it's important to keep the image analysis algorithm in mind. Firstly, to analyze whether the lesion that you're looking at is normal or abnormal. If abnormal, then is it a developmental disorder or is it acquired? If it is acquired, then it would fall under the category of either a cyst, inflammatory lesion, malignant neoplasm, benign neoplasm, bone dysplasia, vascular lesion, metabolic lesion, or lesion due to trauma. While writing a diagnostic imaging report, these are the following important points that need to be present essentially in the report. First of all, the patient and the general information about the patient, what imaging procedure was done, what is the clinical information that is important to correlate with the radiograph, the findings that were seen, the observations from the diagnostic image, interpretation of the image, which includes what your thoughts are on the radiographic differential diagnosis, and lastly, the name and signature of the clinician. Now, with all of this having said, what is important to remember is that proficiency comes only with practice. And is very true for radiographic interpretation. The more radiographs you see, the more likely you are to be able to interpret them with confidence. So let us look at some normal anatomy that could mimic radiographic appearances that we were talking about. And just to keep in mind how the maxillary region looks like, the mandibular anterior region looks like, or the mandibular posterior region looks like. So the arrows here are pointing towards the CEJ and the lamina dura. And in this radiograph up here, you see the lingual foramen. And so anatomy is something which needs to be kept in mind before you are analyzing any area, to understand which region you're looking at and what could be the normal anatomy that could superimpose over the region and aid you in diagnosis. So if you were to look at dental caries, the arrow pointing out here, this is the bite-wing radiograph, and you can see on the proximal surface, distal surface, this is probably the left premolar or molar bite wing, you can see that there's a radiolucency and it's involving the enamel and dentine, and it looks very much like a dental caries. When we're talking about deep caries involving pulp, it involves the enamel, considerable amount of dentine, and very close to the pulp horn. So that is how you analyze whether there is, how deep the caries is, based on the perception of depth of the caries as well as the proximity to the pulp. In case of periodontal diseases, there are certain limitations of radiographs. We must understand that radiographs, plain radiography especially, is a two-dimensional image. So there are a lot of overlapped bony defects which could give you an appearance that the radiograph is actually showing less severe bone destruction. So clinical correlation is very important. So another important thing you need to keep in mind is that pockets cannot be seen. Pockets are soft tissue structures and you can't really assess them on radiographs. So what you can really assess is how much amount of bone destruction has happened because of the pocket in that area. For example, you can easily analyze what is vertical bone loss and what is horizontal bone loss, which is leading to periodontal disease. Now that we've looked at the inflammatory lesions, I've just added some additional notes on how radiolucent and radioopaque lesions or mixed lesions of the jaws can be differentiated. So what I've listed out is a differential diagnosis. More of this can be referred through to as you go through these examples. So, let's look at some radiolucencies of the jaws. This is from a textbook called Wood and Goes. It's a very old textbook and does not have any newer additions to it, but it definitely gives you a good differential diagnosis to start your work with. So, if you were to classify radiolucent lesions of the jaws, then the most important types would be anatomical, radiolucencies, periapical or pericoronal, interradicular, solitary cyst-like radiolucencies, multilocular radiolucencies, solitary radiolucencies which are ragged and poorly defined borders, multiple separate well-defined radiolucencies, or generalized rarefactions of the bone. Anatomic radiolucencies can be seen in the maxilla or the mandible and shouldn't be confused for pathology. For example, an incisive foramen in the maxilla, the nasolacrimal duct, and lingual foramen in the mandible shouldn't be confused for pathology. The best example was that of a mental foramen superimposing over the apex of the premolar, mandibular premolars, being confused for a periapical radiolucency due to a decayed tooth. So these are examples of periapical radiolucencies, pericoronal radiolucencies, and interradicular radiolucencies. The periapical ones would be generally due to pulpoperiapical radiolucencies like the granuloma, radicular cyst, etc. The ones which we've just gone through, you could rarely have some cystic lesions which are superimposing over the periapex. On the other hand, pericoronal radiolucencies are generally the follicular space or the dentigerous cyst arising from around the crown of a tooth. It can also be ameloblastoma or COT or AOT. The interradicular radiolucencies generally arising in between the roots are due to a periodontal pocket or furcation involvement, or sometimes a periodontal cyst, or even incisive canal cyst in the maxillary anterior region. Solitary cyst-like radiolucencies not necessarily contacting teeth could be due to post-extraction socket, a residual cyst, a traumatic bone cyst, or OKC, which could be examples of cyst-like and then appearing in the mandible or the maxilla. Multilocular radiolucencies are the one which have multiple locules. Common examples would be ameloblastoma, the OKC, central giant cell granuloma, myxoma, aneurysmal bone cyst, etc. Solitary radiolucencies with ragged borders or poorly defined borders. Common examples are osteomyelitis, fibrous dysplasia, metastatic tumors definitely, or simply chronic osteitis, which is shown in the pictures over here. Multiple separate radiolucencies with well-defined borders could be anatomical variations like marrow spaces, or multiple myeloma, like showing the punched out radiolucencies in the picture here. Generalized rarefactions in the jaw bones could be because of bone disorders like hyperparathyroidism, leading to bones or called as bones tumor, osteoporosis, or other malignancies like leukemia, Langerhans cell disease, etc. When it comes to radio opacities of the jaws, radiopaque lesions of the jaws could be again anatomical, periapical, solitary radiopacities which are not contacting teeth necessarily, or periapical separate radiopacities, multiple separate radiopacities, or generalized radiopacities. So, if you were to look at anatomic radiopacities, they could be common to both the jaws. In the maxilla, you could simply have the zygomatic bone or the nasal spine, which is looks like a radioopacity, and in the mandible, it could be the mental ridge or the mylohyoid ridge. True periapical radiopacities are like condensing or sclerosing osteitis, cemental dysplasia, hypercementosis, whereas false ones are anatomical structures or supernumerary teeth which are superimposing over the existing periapical region. True intrabony radiopacities are like tori, exostosis, or idiopathic osteosclerosis, for example, in this case, which is not necessarily contacting the tooth and is slightly separated from the apex and it appears in the periapical region, though, and that is a idiopathic osteosclerosis. Projected radiopacities could be foreign bodies or soft tissue masses which are superimposed over the jaws, and multiple separate radiopacities could be there, which are like multiple retained roots or impacted teeth, calculi, and generalized radiopacities like florid cementoceous dysplasia, Paget's disease, or osteopetrosis. Mixed ones, there's a wide variety of mixed radiolucent radiopaque lesions. They could be associated with the teeth and not necessarily contacting the teeth. The ones which are associated with the teeth could be the periapical or pericoronal, close to the pericoronal area. The periapical ones could be calcifying crown of a developing tooth or simply rarefying and condensing osteitis, pictures of which we've just seen. Pericoronal lesions, which could be adenomatoid odontogenic tumors or COC, amyloblastic fibroodontoma, all of which appear mixed in origin. Mixed lesions which are not necessarily contacting teeth and are separated from the teeth could be like chronic osteomyelitis, osteoradionecrosis, fibrous dysplasia, or even chondromas and chondrosarcomas. So that brings me to the end of this chapter. I've given you a broad view of how to diagnose or basics of principles of radiographic interpretation. You can build up more on this by referring to the textbook, and it's really important that you go through more and more radiographic pictures or in the textbook to give you an idea how variations of the lesions that we've described look like. Thank you.